Hi, I'm Larry Needleman. I'm the medical director of the non-invasive vascular lab at Thomas Jefferson University Hospital. This lecture is about upper extremity venous ultrasound. The upper extremity venous examination is being increasingly ordered for patients with indwelling catheters, prior to the placement of indwelling catheters, or patients with arm swelling. This mirrors the etiology of upper extremity thrombosis. In prior years, before catheterization was so common, physical strain such as lifting, certain exercises such as weightlifting, were associated with this disease. These are all much rarer now. Today, the overwhelming presence of upper extremity thrombosis is associated with catheters, either in place or pre-existing catheters where there has been scarring of the vein. And in many cases, the presence of hypercoagulable states, as patients are living with their cancers longer, hypercoagulable states are present, and thrombosis in less usual spots than the lower extremity, such as now upper extremity, are also present in up to 15% of patients who have upper extremity thrombus. There are a variety of other etiologies for this, but they are far less common. The anatomy of the upper extremity veins is quite different than the lower extremity in that we have the bony thorax, which covers many of the veins, and the presence of numerous collateral vessels and numerous other vessels which are present besides the large veins that we evaluate. And these veins can grow quite large as collateral vessels and can mimic the veins that we typically study. In lower extremity venous examination, compression is the most useful part. Duplex and perhaps color are secondary players. In the upper extremity, because we can't compress many of the veins and because blood flow is faster, we can utilize all of our modalities, and they're all very important for diagnosis. So grayscale imaging, color Doppler, and spectral evaluation are all used to evaluate these veins. In terms of technique, the patient should be lying supine and in a symmetrical posture because symmetry is going to be quite important for evaluation. We prefer a small footprint transducer. Oftentimes we use transducers which are appropriate for neonatal head ultrasound because it offers a vector scan and a small footprint from which we can see inside the thorax. As a general rule, a supraclavicular medial approach is used for the central veins. An infraclavicular approach is used for the peripheral subclavian and axillary veins. From our technique point of view, we typically are studying the jugular vein adjacent to the carotid, angling down or obliquely to evaluate the right and left innominate veins, scanning then out peripherally to evaluate the subclavian and axillary veins, and compressing the arm veins as needed. In some patients who have clear-cut arm abnormalities, such as patients who have arm swelling following an intravenous catheter placed peripherally, we might limit the study to the arm alone. But the vast majority of patients who are evaluated for this DVT, the central veins, are evaluated as well as the arm veins. Simplified view of the anatomy of the central veins is demonstrated here. We can see the jugular vein, the subclavian vein, and they join to form the innominate vein. On the right, the innominate vein has a coronal orientation. Here, the left jugular and left subclavian, and the left innominate vein is longer and has a more oblique orientation. The two innominate veins together join to form the superior vena cava. Small footprint transducers are quite important. The good news is the color Doppler and filling of the entire vessel is easier than in lower extremity. We can also use other tricks such as sniffing, where compression is impossible. And again, bilateral studies are the usual in these patients. Here we are using a curved array transducer, and we can see that because of all the fat and material in the mediastinum, the veins are somewhat more filled in with echoes than perhaps we're used to. But we can see that even with this, with compression, the vein goes away completely, leaving just the artery. And so this is a normal collapsible vein. Here in the innominate vein, we can see the structures of the vein, and you can see that as we take a sniff, the change in the intrathoracic pressure can cause the vein to change size and actually disappear. And if we can see the veins collapsing completely with sniffing, then we can actually accept that just the same as if we were compressing it with probe pressure. The Venous Protocol in the upper extremity uses imaging, color, and spectral Doppler. And we use all three modalities for the subclavian, jugular, and nominate veins. And if we see the superior vena cava, we evaluate that as well. We typically try to look in both long and short axis, but in some veins that's not possible. The innominate vein is typically a vein that we can only image in one plane, and we scan from anterior to posterior to see as much of it as we can. Again, we recognize that because of beam width artifacts in the presence of the nearby pleura or lung or mediastinal fat, that there may be echoes inside of these structures. Compression is appropriate and used whenever possible, and that includes the peripheral subclavian vein, the jugular vein, the axillary, and the arm veins. As a rule, we scan in the following order. We start in the jugular vein, proceed to the innominate vein, then the central subclavian out to the mid-subclavian, peripheral subclavian, axillary, and arm veins. Let's look at some images. This is the common carotid. This is the jugular vein in short axis. Here in long axis, we can see the jugular vein changes shape a little bit as we go from cephalad to caudad. It gets a little bit bigger. Again, asymmetry between the left and right jugular veins in terms of size is not unexpected. Waveform shapes in the upper extremity veins are quite typical. We can see variation from phasic variation. Here you can see the vein nearly stopping and then going back to a more phasic change. We can also see that there is cardiac variation in this waveform. This waveform to the lower right demonstrates much more profound cardiac variation with some areas of reversal related to the A's and C waves. And again, you can see that that's present as well as a slower change in peak velocity as related to here and here, indicating respiratory change. So we have both respiratory, phasic, and pulsatile cardiac variation. So the central veins, typically the central, innominate, and sometimes the jugular veins, demonstrate pulsatile and phasic variation. Peripheral to the mid-subclavian, we will see phasic variation, and we may or may not see pulsatile variation. We do expect to see symmetry, so if one arm demonstrates pulsatile variation, we expect the other arm to show the same degree of pulsatility. We also expect to be able to fill the entire vein with color. Looking at some other waveforms, here the coronal orientation showing us the innominate vein. We can see the innominate vein here, the subclavian vein joining, and this structure is typically not the external jugular vein that we're used to seeing, but another vein, typically another anterior jugular vein. The innominate coming away from us, we see it filling completely in color, and our waveform shape showing again the difference in variation in velocity from respiratory change, as well as the superimposed greater changes indicating cardiac pulsation. Cardiac pulsation can be much more prominent and can cause aliasing because of the higher velocity, as we see here. And in the color, we can also see the aliasing related to the higher velocities that are present in the upper extremity veins. And aliasing is much more common in the upper extremity compared to the lower extremity. As we proceed We angle our transducer to bring in to view the central subclavian vein, here joining with the innominate vein, and the color filling in of that structure as well. And again, our normal pulsatile and phasic variation on our spectral Doppler. As we scan to the mid portion of the vein, we realize that the angle of the vein may make it impossible to see the vein completely, as it will travel through 90 degrees, and we need to therefore angle our transducer backward and forward, as demonstrated by the two right-hand slides here. Here we can see the mid-subclavian vein throughout its whole course, but not being able to be evaluated throughout with one image because some of the vein is at 90 degrees to our transducer. And we can see that we can evaluate this as well with our spectral Doppler, indicating our pulsatile phasic variation. Peripherally, the subclavian vein can be seen quite well in both long and short axis, as identified by the color images above, and we can see the normal spectral Doppler tracings in the peripheral subclavian vein, again showing relatively high velocity flow during part of the cardiac cycle, or part of the respiratory cycle rather, here on the left example, and on the right example showing diminution of the flow velocity, also related to respiratory change. Axillary veins may demonstrate some reversal or may just be phasic, looking more like a leg vein, but in most cases you can identify a bit of flow reversal in the axillary vein. I remind you that the peripheral subclavian and axillary veins can also be compressed. The left innominate vein can be seen in part of its course, and we never usually see the entire course of the right or left innominate. Its junction with the superior vena cava is usually not visible with our transducers, but again we can see this oblique course of the innominate and the normal spectral variation that's present. Here in a very unusual example, we can actually see the right and left innominate coming together to form the superior vena cava adjacent to the aorta. Again, this is a very pretty picture, but one that is unusual to obtain. So what criteria can we use for abnormalities? Well, if the pulsatile variation is lost, even if respiratory variation is present in the central veins, that is abnormal. Obviously, more profound blunting of the signal, such as a continuous signal, an absent signal, are also indicative of abnormalities. One of the aspects of the upper extremity is that collateral flow can happen, and so the normal obstructed signal may not be present, but the vein may just show flow in the reverse direction. Also, because of the higher velocity and the presence of catheters that stenose the veins, we can sometimes see areas of narrowing associated with high velocities, a stenotic jet indicating a stenotic vein. And lastly, of course, we always consider bilaterality and asymmetry as a sign that central obstruction may be present. Here in this subclavian venous waveform, we can appreciate the fact that there is little variation with respiratory change and no cardiac variation. This indicates that there is obstruction of flow. On the right, we can see an axillary waveform which is showing some phasic variation, but when we compare the two sides, we immediately appreciate that the waveform on the right is clearly blunted compared to the left, and this asymmetry again indicates obstruction in a vein proximal to the axillary. This could be at the subclavian or innominate level. We can't know where the level of obstruction is unless we identify it directly. Echoes inside the veins are extremely common. We want to look at the echoes inside the vein and see if they are fixed in position, which would indicate a fixed filling defects like a thrombus, or whether they are moving through the field, such as happens in rouleau, where the slow-moving flow moves through in one direction, or whether this simply represents noise from beam width artifact. And here, as we can identify in our color, the vein fills in completely, indicating that this is just normal noise in this particular patient. As I alluded to before, if there's obstruction, the flow can reverse. Here we can see actually a patient with acute deep venous thrombosis. We can see the waveform. The color of the vein is red, which is the same as the carotid artery near it, so blood is flowing towards the head instead of towards the heart. But a few months later, after this resolves, the vein has a more normal shape, and the color is now flowing in the proper direction. The jugular vein is the most common place to see reverse flow, although in more central obstructions you can even see it in other veins such as the innominates or subclavians. Let me first point out the central subclavian vein here, which has this very high velocity waveform shape to it, indicating a jet. As we go peripheral to the subclavian vein, the waveform is blunted. We don't see the normal pulsatile or phasic variation. This indicates obstruction. When we have an abnormal Doppler, it indicates obstruction. The etiology is not necessarily identified, and as we know from the lower extremity, the obstruction may be acute, it may be chronic, or it may be extrinsic. The site of the abnormality indicates the level of obstruction. So for instance, if all of your veins, the innominate, bilaterally, subclavians, and jugulars are all showing blunting, then the waveform and obstructions are created from the level of the superior vena cava. If the innominate on one side is normal and the innominate on the other is blunted, the obstruction is at the level of the innominate on the affected side. If you see an abnormality in the Doppler but can't figure out why it is being caused, the report should say that there is obstruction, and it should give a differential of the level of disease and the possible etiologies that are present, and to recommend perhaps other imaging such as CT or MRV, or rarely, or more and more rarely now, contrast venography. Not only is the Doppler important, but imaging is important. As I mentioned, grayscale is important for imaging the thrombus itself. Our ability to see the thrombus varies by its echogenicity. As we've seen, noise may occur in the vein which can obscure or mimic clot. And so color becomes very important to identify thrombus as a filling defect in the color column. And in veins that are compressible, non-compressibility or sniffing may be helpful. Here we have a catheter present within the vein, and we can see low-level echoes lying in the lower portion of this vein. This is not reverberation, as the echoes are not in the upper part of the vein, and you can see here on the short axis view that again the upper portion of the vein is anechoic, and this represents pericatheter thrombus. Color is not always helpful in identifying the filling defect if you're not careful, because as you see here, the color is overwriting the thrombus, and so you have to be very careful with your color gain to make sure that you're not overwriting the low-level echoes that may be present within the thrombus. The criteria for acute thrombus are that it expands the vein, that it's free-floating, that it's smooth, and when we can compress the vein, it can change shape because it's still rather soft. Here we can see a jugular vein thrombus, which is markedly enlarged compared to the corresponding carotid artery, and this indicates marked distension from acute deep venous thrombosis. In this case, we can see the thrombus, which is rather echogenic and heterogeneous, but what's striking is as we follow the edge of the vein wall, we can see that it distends out in this region. Again, the distension indicates acute axillary vein thrombosis. The echogenicity of a thrombus is not helpful to determine whether it is acute or whether it is chronic. Whenever we see catheters, we want to look around the walls of the catheters to see if there's echogenic material within them. And here you can see this echogenic heterogeneous material associated with this triple lumen catheter, indicating an acute pericatheter venous thrombosis. When we can compress in the mid-region, we can see the lines of the catheter. We can see that the catheter is sitting inside the middle of the vein, but there are many, many echoes within the vein. And when we compress, that those echoes don't disappear and that we can't make the catheter disappear, the vein disappear completely. Even in the presence of catheters, the vein should be completely coaptable around the catheter. And the presence of residual vein around the catheter indicates pericatheter acute deep venous thrombosis. Here, a slightly different image where we can see a catheter again, and this fine material which is sticking out of the vein, and this more linear material, which is kind of almost looks like a Q-tip hanging off the edge of the vein, is much more typical of fibrin sleeving as opposed to pericatheter thrombus. Let's look at some pitfalls. Again, we have to be careful that color may overwrite our image, and this again reiterates to us that grayscale is important. Similarly, if the thrombus is small, it may not cause distortion of the spectral Doppler. So here we can see the spectral Doppler is normal. The color is really not helpful, but when the color is turned off, we can see that there is some asymmetrical echoes on the wall of the vein here in the subclavian vein near the innominate junction. And as we change our orientation and scan back and forth across that vein, now we can see from a different plane the thrombus, which is now projecting in a different plane, again front to back, and we can now diagnose acute deep venous thrombosis. The same thrombus which we did find could be seen with a linear array probe, and so we can appreciate the fact that we can use a variety of probes that are helpful to us. In fact, here in the linear array probe, we can see that there is thrombus which is present inside the vein and extends down, and then as we go further peripherally we can actually now see the catheter and the echogenic pericatheter thrombus around it. You'll note, by the way, that the catheter isn't seen on either of the images on the above, and that's because unless you hit catheters at the proper angle, because they're specular reflectors, they may not be obvious. And so we do not always follow the catheters, even though we know they're present, and they can't always be seen throughout their entire course, even when we know they're in the vein. Another example of very echogenic looking veins, and it's very difficult to distinguish between noise and thrombus, but when we turn the color on, we can see that the vein changes caliber from rather large to rather small around a structure. Again, this is in power Doppler. Here in the lower left, here in the upper right, we can also see the filling defect with color Doppler. And now, as we angle and rotate our transducer from a different orientation, we can see the echogenic thrombus projecting from a different wall in the innominate vein. So the color, again, can overwrite the clot, but also can point to clot in other cases. In distinction between acute venous thrombosis, scarring is very frequently found in these patients because the catheters are sitting inside for long periods of time, and the veins will scar as a result. Scarred veins typically are normal or small. The material of the scar is firm, irregular. The vein may retract and be pulled in. We can also sometimes see circumferential narrowing or web-like changes, although circumferential narrowing, in my experience, is more common than synechiae in the upper extremity compared to lower extremity. And of course, stenosis, and we need to recognize that arm swelling may be caused by stenosis and not always by acute venous thrombosis. Here we can identify the vein. It's filled with middle-level echogenic material, and the lumen is reconstituted in a regular shape, smaller in this region, larger in this region. And this irregular lumen, again, indicates the recanalization, partial recanalization of the material and the scarring in the vein. So as we look at upper extremities, we realize that there are many, many more difficulties because of our inability to see the veins in all planes, and we can't compress all the veins that are present. In addition, we have to be very careful about echoes inside the veins either being caused by reverberation or noise. We always need to remember that the Doppler, the spectral Doppler, may not be altered if the thrombus is not large enough to obstruct the vein, and that collaterals may mimic a normal vein. Here we can see reverberation. As we scan down the middle of the vein, you can see the reverberation fills the lumen, and at the periphery where we're not striking the veins at the same angle, the vein lumen is anechoic. And then as we look with color, we can now fill the vein in quite adequately. And as we change the orientation of our image, in fact, we can see that the echoes move to different portions of the vein, up and down. And finally, we confirm that it's normal with both the presence of a normal spectral Doppler and the presence of a normal color Doppler, which fills the entire vein. So now a question. We have a short axis view in the subclavian area. We have an arterial signal and a venous signal and two echogenic structures. What do you think is going on? Is it breast cancer? Is it venous obstruction? Is it venous occlusion? Or is it a combination? Well, the first structure that we see are two soft tissue structures which don't correspond to veins, and those do represent metastatic breast deposits. When we do the venogram, we see that the subclavian vein is completely obstructed. As we go back to our image, we appreciate the fact that this small echogenic structure here is the subclavian vein, which is obstructed chronically and therefore small. And this other structure here is not the subclavian vein, but instead is a large collateral which mimics the subclavian vein. And as we scan in different planes, we realize that it no longer follows the subclavian artery, but goes off in an entirely different direction. So remember, one view is not adequate enough to make sure that we're looking at normal vessels, and you really want to show that the entire vein is running in normal orientation. Here we can see a series of images, and there is some pulsatile variation. There is some phasic variation. We can see the phasic variation nicely in the subclavian. We can see some of the pulsatile changes. Here, again, some of the pulsatile and phasic variation in the peripheral subclavian. The innominate vein showing some phasic variation, pulsatile variation, not so much, but it is seen a bit more in the subclavian, and so this, I think, is a rather difficult study to interpret, and it certainly could be considered normal. However, when we compare the right side we just saw with its corresponding left side, we can immediately appreciate the asymmetry, the normal extreme pulsatility that should be present, and therefore it's no problem to diagnose the right side as blunted, indicating obstruction at the right innominate level. So I hope we reviewed successfully for you the techniques and interpretation of upper extremity venous disease.